Okay. Good evening, everybody, and welcome to this fellow session of GECO, which is, of course, hosted by the Gastro Foundation in association with Project ECHO of the University of New Mexico. It runs, of course, every second Monday at 1800 hours. So today our presenter is Pascal Kuka from Gauteng, and he's going to present on advanced therapies for IBD. So Pascal, if you want to start screen sharing. Perfect. It just needs to be on slideshow mode. Perfect.
Okay. So thank you very much, Prof, for the introduction. So welcome, colleagues. Welcome to our last academic G-ECO session for the year. Our topic today is advanced therapies in IBD. As you know, we've had the IBD module that has been running for a couple of months now, and you are finally culminating into the advanced therapy. So the last discussion we had was about conventional therapy, and we saw that they're highly effective, especially in mild moderate disease. But we consider advanced therapies in patients who fail or are intolerant to conventional therapy. Other than that, patients who also have a high disease burden, not only the primary disease, but also on occasions with the high extraintestinal disease burden, can also be considered for the same. Also, patients who are at high risk of complications will also be considered for advanced therapies. And the goal, amongst other things, but the key goals to avoid any disease-related disability and also maintain a good quality of life. So when you talk about advanced therapy, it's hard to discuss about it without having to look a bit about the pathophysiology. We all know about the four tenets of pathophysiology of IBD, but the main one that will be key in terms of a discussion on advanced therapy is immune dysfunction. So immune dysfunction in IBD, it's very complex. There are lots of factors that are interplay, as you can see from this representation. However, the key representation is that there could be antigen that are presented from whichever source, either from the differences in the gut microbiota or from the colon lumen, which then activate this downstream series of immune mediated signals. So in terms of therapy, we are not only targeting the immune mediated at the level of the intestines, but as we shall see, we also target at the level of the vasculature and even far beyond in terms of the source into the lymph node tissue. So we look at the different drugs as we go through our discussion. So in terms of advanced therapies, the two big main differences are the biologics and the targeted small molecules. So the biologics are large and complex, and because they're also synthesized with in living tissue, they also tend to be immunogenic, but different levels of the same, as opposed to the targeted small molecules, which are non-immunogenic. Biologics are administered either intravenously or subcutaneously, as opposed to targeted small molecules, which are admitted orally. The half-life has a key implication in terms of how we space out the treatment for biologics, most of them in between weeks, as opposed to targeted small molecules, which are given daily. In terms of the target, biologics mostly act on the extracellular, so in the cytokines and the receptors, as opposed to the small molecules, which target the intercellular signals. So this is a famous slide across many discussions of advanced therapy, but as you can see, it's an evolving field. For example, the echo talk that we had the last time, this a bit updated. We didn't have some of the drugs that have been approved since the last discussion that we have. So, and not only new approvals, but we also get new formulations. For example, infliximab, as you can see in 2003, it was approved in terms of having a subcutaneous use, as well as vedolizumab, which in the last couple of years has also been approved for subcutaneous use. So we'll start with the anti-TNFs. So still back into the pathophysiology of IBD. So TNFs play a major role in terms of being presented, in terms of the antigens being presented to macrophages, and then stimulation by secretion of TNFs. So TNF have different receptors, one being TNF receptor 1 and TNF receptor 2. These have different downstream effects in terms of activation of other immune cells, but also the TNF themselves being effector cells, and also signaling other multiple inflammatory pathway. So this can lead to more inflammation as well as effector cells in terms of apoptosis and necroptosis. So it follows this that drugs which can target the anti-TNF will have a role in IBD. So as we talked with the landscape, the first drug that was utilized in IBD was infliximab, first from a case report in the Netherlands, and then later on from studies including the the ACCENT for Crohn's disease and the ACT for UC. Then followed adalimumab, which as you know is a humanized antibody as opposed to infliximab, which is a chimeric, for which the main trials of the CHARM and the ULTRA. So the anti-TNFs have been utilized for the longest period of times in terms of the biologic, and because of that, we have long-term data, not only for the effectiveness, but also comparative to other of the new drugs in terms of head-to-head trials that we shall see as we go along. Golimumab and satolizumab, although they're also approved, they're only approved in UC and Crohn's disease, respectively. So the use of anti-TNFs in IBD, there are some, hardcore indications for which have been approved and also have been studied long term. The first one is acute severe UC. The next one will be the use of infliximab and adalimumab in perianal or penetrating Crohn's disease. And although there are also other, drugs that can be utilized in spondyloarthropathy, but axial spondyloarthropathy has a key role in terms of utilization of anti-TNFs, as well as the extraintestinal manifestation of pyoderma gangrenosum and refractory, keyword being refractory, uveitis and scleritis. So in terms of the treatment, it's been shown that if we initiate but in anti-TNFs, in this case infliximab, early enough, we can actually prevent patients from having long periods of steroids, as well as being free of surgery. This is a study that was done just this year, which showed significant differences in terms of what was traditionally known as top-down versus step-up therapy. So we need to consider early treatment in failed conventional therapy, in the key being not having the patients having to earn biologic therapy. And in this case, we're talking about anti-TNFs, but just generally all the biologic therapies. And then you also need to consider that in high-risk patients, in Crohn's disease being young, patients who have an ileal allocation, and also patients who have extensive disease, including fusarializing disease. And you've also mentioned about the fact of refractory extraintestinal manifestations. So one of the key drawbacks in the use of anti-TNFs is the immunogenicity. It's already been proven that combination of infliximab with a modulator being azathioprine has been improved mucosal healing compared to azathioprine monotherapy, and also slightly better compared to infliximab monotherapy. However, we need to consider the use of azathioprine monotherapy in terms of other risks. One of the risks being development of lymphoma. So the patients who are at risk of development of lymphoma will be patients who are elderly, as well as young males who are at risk of developing hepatocellular T-cell lymphoma, but also patients who will have a long duration of treatment with azathioprine. As I had mentioned before, because of the long use of anti-TNFs, we have multiple cohort or follow-up studies. So one of them is a PANT study, which is a cohort study that looked at patients in the UK. We have a PANTS 1 and a PANTS 2 study, which has been able to show patients who are at risk of failure with the use of anti-TNFs. The two predictors were one, a low drug levels at week 14, presence of antibodies, and this particular HLA-DAQ 105. So this begs into thinking about the two different concepts in terms of monitoring, the so-called proactive monitoring, where you monitor your drug levels and your presence of antibodies at select intervals, as opposed to reactive monitoring, where you only check the levels when there is an improvement in terms of symptoms, or whether you think that the drug is not working. However, as much as the proactive monitoring might sound appealing, but recent trials have shown that there isn't any clinical benefit in proactive monitoring. But as it will rightly say, there will be increased cost because of the frequency doing the tests. So this leads us to the issue about the loss of response to TTNFs. So the loss of response can be either primary, which can involve either the drug in terms of the dosages, or also in terms of the drug levels, as opposed to the dynamics in terms of how the patient is able to either break down or not be effective the drug. There being different modalities, things like the weight, the level of inflammation, the albumin level, as opposed to secondary response, where patients who previously had a response to treatment then develop a loss of response, which can either be mechanistic or immunologic. So, in terms of monitoring these patients, the key things that are checked for are one, the drug levels as well as the antibody levels. And with those two different measures, you're able to decide whether indeed you need to do class switching, either within the class or out of the class, as well as initiation of an immunomodulator in case the patient is not on any. But in cases of where you don't have any antibodies, then consideration of dose escalation, which, as you know, can be done in terms of either increasing the doses or reducing the frequency of administration of the drugs. So back to the PANS cohort study, the same study looked at patients who've been on anti-TNFs for up to 36 months. So it's been shown that progressively there are more and more patients who develop treatment failure. At about 36 months, only between 30 to 40% of patients were actually in remission, as opposed to those who exited due to the treatment failure. So this is one of the reasons in which we really need to be careful about the medications that we're selecting, especially the first medication, because as we shall see, there is something called the law of diminishing returns, where with subsequent use of biological or advanced therapy, then they are less and less effective. So in terms of safety of anti-TNFs, as I said, not only in IBD, but anti-TNFs have been utilized in other different diseases. And with that, we have some long-term data in terms of the safety. So opportunistic infection we all know is a big issue in the use of anti-TNFs. That's why we screen for TB, we screen for hepatitis B prior to initiation of treatment. In terms of opportunistic infection as well as reactivation, there is an increased risk of malignancies, especially lymphoma and non-melanoma skin cancers. We always need to make sure that the patient doesn't have any features of heart failure prior to initiation of anti-TNFs. And then also, anti-TNFs can precipitate the malignant conditions like multiple sclerosis or optic neuritis. The other complications, including the liver toxicity, can be considered as mild complication. So, although we are moving to the next group of drugs, we still keep on, looking at the TNFs, especially when it comes to head-to-head trials involving other advanced therapies to TNFs. So the next group of drug will be the anti-integrin inhibitors, also known as the leukocyte trafficking inhibitors. So as we know about the immune mediation in IBD, and one of the key issues is attraction of leukocytes to the intestinal mucosa. So leukocytes, by attraction, they undergo different stages in terms of tethering. That's what's happening in the vascular space. So they tether, they roll, and then they have ligands called integrins, which are activated. And using the ligands, they're able to attach onto different adhesins on the vascular mucosa prior to undergoing the apedesis and going into the intestinal space. So one of the integrins that is expressed is the alpha 4 beta 7 integrin, which is gut specific as opposed to some other integrins, including alpha 4 beta 1 integrin. So it follows that inhibition of the integrin will inhibit the outflow of lymphocytes or leukocytes into the intestinal space. So as I mentioned, alpha 4 beta 7 is gut specific as opposed to alpha 4 beta 1, which is mostly in the brain, and it's utilized in terms of use of natalizumab in multiple sclerosis, which then predisposes patients to complications. The key one being PML, primary multifocal leukoencephalopathy, which was initially a concern with vedolizumab, but we shall see it's not a valid concern anymore currently. So what evidence did you have to use vedolizumab, especially in Crohn's? So the Gemini 2 trial in 2013 is what established the use of Crohn's. So in terms of the induction, there was, a 31% in terms of clinical response. But in terms of, after 42 weeks, there was significance in terms of clinical remission as compared to placebo, more so with the 8 weekly doses, which has been what has been utilized. The Gemini trial also, of vedolizumab in ulcerative colitis also established the use of it, which established, significance in terms of clinical response at 52 weeks, with the 8 weekly doses achieving up to 41%, as opposed to, a bit higher in terms of the 4 weekly doses, but all of them were significant compared to placebo. So, as I'd mentioned before, we currently have some head trials, one of them being the Varsity trial, which compared vedolizumab and adalimumab, which, as you know, is anti-TNF in ulcerative colitis. It showed that vedolizumab is non-inferior to adalimumab in terms of clinical response, but then in endoscopic improvement, it was actually superior to adalimumab. That's at 52 weeks. So again, another cohort study that looked at patients in the UK who had been on first-line antibiotics, and this looked at vedolizumab and as well as other anti-TNFs. And within 5 years, it was found that more patients on vedolizumab were actually free of treatment discontinuation or treatment failure, as opposed to the anti-TNFs that are utilized in the cohort study. So, as I'd mentioned before, we're also having, approvals for other modes of therapy. So, subcutaneous vedolizumab has been approved in the Visible trial, which was found not to be inferior to the use of, IV vedolizumab in terms of endoscopic and clinical remission. So, what about the safety? Again, there's a Gemini long-term trial which looked at more than 20,000 patients. And there is, in terms of infections, the risk of infections is less than 10%. And in terms of the infections, just because of vedolizumab being gut-specific, there was a concern about gut-related infections, including specific infections like Clostridia, but also other organisms like Campylobacter. The risk of malignancy is very low, less than 1%. And in that follow-up period, there are no cases of primary multifocal leukoencephalopathy, which, as I said, is a concern in the brother to vedolizumab being natalizumab. In terms of extraintestinal manifestations, there is actually development of arthralgia as one of the extraintestinal manifestations. So because of that, vedolizumab is not considered strong in terms of using it for patients who have arthralgia as one of the extraintestinal manifestations. So we'll now move on to the next group of medications, which is IL-12 and IL-23 inhibitors, which can also, in other texts, can also be considered, separate. So interleukin 12 and interleukin 23, they are found on different, T helper cells. In terms of interleukin 12, it actually, it's found on naive T cells, and activation of it then promotes naive T cells into T helper cells, which then secrete specific interleukins and also tumor necrosis factor. So if you look at the structure of interleukin 12, it has two subunits, the P40 and the P35, as opposed to interleukin 23, which shares the P40 subunit, but also a special P19 subunit. In terms of medications, ustekinumab is non-selective in terms of inhibiting both the interleukin, the P40 and P19. So because of that, it has effects both on the interleukin 12 and the interleukin 23, as opposed to the other drugs, risankizumab, mirikizumab, and guselkumab, which are specific to P19 of the interleukin 23, subtype of interleukin. So also just mentioning some of the key trials, as you know, ustekinumab was the first drug that was approved in terms of use of in IBD, But prior to that, it had actually been approved in use of, psoriasis, both plaque psoriasis and psoriatic arthritis. And that is also utilized in terms of extraintestinal manifestations of IBD. The key trials, as are listed, but one of the key things about this group of drugs is that there have been, a number of head-to-head trials, not only within the class, but also with other medications in other classes. And we shall look at some of the head-to-head trials. So we'll start with the CView trial, which looked at ustekinumab versus adalimumab in patients in Crohn's disease patients who are biologic naive. And the trial established non-inferiority of ustekinumab compared to adalimumab in terms of efficacy for clinical remission, as well as, other patient-related symptom, reports. However, as you know, because of the, high risk of infections, high risk of infections of adalimumab and ustekinumab, this trial can be significant in patients who are thinking about the risk of infections. The next head-to-head trial was within the class, comparing risankizumab versus ustekinumab, also in Crohn's disease patients. But this particular group of patients were patients who had failed or were intolerant to anti-TNFs. So this study, established an inferiority of risankizumab in clinical remission, but it established superiority of risankizumab compared to ustekinumab in endoscopic remission at week 48. The next, in terms of the head-to-head trial, another head-to-head trial was the VIVID-1 trial, comparing mirikizumab versus ustekinumab. And this trial, of course, it showed the superiority of mirikizumab compared to placebo, but there was non-inferiority of mirikizumab compared to ustekinumab in patients who are not only biologic naive, or patients who have, already been on biologics. But although there was non-superiority, but there is just a bit of increase, a bit of better percentages in mirikizumab. But as I said, it was it was found to be non-inferior. Another of the head-to-head trials was Galaxy 2 and 3, which compared guselkumab versus ustekinumab, which showed, in terms of clinical response and endoscopic remission, the endoscopic response, the guselkumab was superior to, ustekinumab, but it was non-inferior in other indices that we mentioned. So what about safety of this group of drugs? So they actually considered safe. Some of the side effects, what you can consider minor side effects, including side effects related to the administration of medications. And actually, a Cochrane review has said that there isn't any risk of adverse or any serious adverse events, in this case, looking at ustekinumab when compared to placebo. But because the newer drugs are a bit newer, we hopefully will get more data in terms of long-term efficacy of the same. But hopefully, they will mirror what we've seen with ustekinumab. So now we shall go on to the small molecules, starting with the JAK-STAT inhibitors. So, in terms of the mechanism of JAK-STAT signaling pathway, so this is one of the signaling pathways that is utilized in multiple other organs or systems within, in multiple organs. So specifically, once you have activation of the JAK, then you have a downstream, activation of STAT, which then has some particular effects on different target genes, not only inflammation, but also multiple other, dimension in terms of organ function. So it follows that inhibition of JAK-STAT might inhibit target genes which are involved in pro-inflammation. But as I said, it is not only inflammation, but other different organs. So there are different kinds of, the different kinds of JAK receptors. So there's a JAK1, 2, 3, and the TYK. But they're all in different combinations in terms of how they are attached to the interleukins. So, in terms of medications, we have medications that inhibit all the JAK. In this case, tafasitamab inhibiting JAK1, 2, and 3, as well as TYK. as opposed to upadacitinib and filgotinib, which are the three drugs which are relevant to IBD, which are JAK1 specific. As you can see, they inhibit the different combinations which involve JAK1. In this case, then they have the downstream effect of reducing inflammation and also B cell differentiation. So, we might ask ourselves, having a pan-JAK inhibitor, like ideally, you will imagine that it will be more effective more than the JAK1 inhibitors, but we shall see JAK1 or specific inhibitors are actually more effective and have less side effects. So this has thought to believe that probably some of the side effects of JAK inhibitors might be affected by the other non-JAK1 receptors. So one of the key drugs is upadacitinib, which, as I said, is approved in Crohn's disease and UC. The first trial was an induction trial of UXL and UXID, and then later on proceeded to the maintenance trial of UENDUO, which the induction dosages were 45 milligrams for 12 weeks, and the maintenance dosages were 15 milligrams or 30 milligrams daily or placebo. And in terms of clinical response at 52 weeks, there was a 47% for 30 milligrams and 37.2% for 15 milligrams, which are all significant compared to placebo. In ulcerative colitis, the induction trials were UAchieve and the accomplished trial, which in terms of induction utilized 45 milligrams for 12 weeks, and clinical response was significant at 26 compared to 5% of placebo in the UAchieve trial, and some of the similar results were also achieved in the UAccomplished trial. In terms of maintenance, the 30 milligram was, achieved clinical remission of 53 compared to 40 for 15 milligrams, with a significant compared to placebo. So because of the different dosages, it's advocated that patients who, have previous biologic exposure, or patients who are at high risk in terms of their disease profile, will be considered for 30 milligrams in terms of maintenance, as opposed to the 15 milligrams. So what about tofacitinib? So the OCTAVE trial was established the use of tofacitinib in ulcerative colitis, in the induction and also the sustain, being significant in terms of clinical response at 52 weeks. Unfortunately, the use of tofacitinib in Crohn's disease didn't achieve success in terms of the trials, and because of that, tofacitinib is not utilized in Crohn's disease. So what about the safety of JAK inhibitors? So previously, there was a concern based on long-term studies for JAK inhibitors in patients with rheumatoid arthritis. So there was a concern in terms of the risk of cardiovascular events being stroke, myocardial infarctions, and death from cardiovascular causes. However, when they had a further look in terms of the patients who had the cardiovascular events, it was found that there are patients who had other risk for cardiovascular events, being more than the age of 65 years, and also patients who are smokers. Further to that, there was a review in terms of review and meta-analysis for use of upadacitinib in Crohn's disease, which actually didn't establish any increase in terms of the cardiovascular events in Crohn's disease. So because of that, there was an echo statement that actually said that there isn't any increased risk of cardiovascular events in JAK inhibitors in patients with, either Crohn's disease or ulcerative colitis. But that does not mean that JAK inhibitors are devoid of any safety concern. So some of the safety concerns will be the risk of venous thromboembolism, being PEs and DVTs. Herpes zoster infection is also one of the key, side effects of JAK inhibitors. And because of that, it's actually advocated that patients are given vaccinations prior to initiation of JAK inhibitors. Because of one of the mediation of JAK is in terms of control of the cholesterol. So there is also a increase in cholesterol levels, both the total cholesterol and the LDL, as well as a decrease in the HDL in patients who are JAK inhibitors. But only few of them in the previous studies required initiation of statin. Infection risk include mild infections like nasopharyngitis, JAK inhibitors, as well as the next group of small molecules, are teratogenic and therefore not utilized in pregnancy. Another of the complications will be cytopenias and the elevation of the creatine phosphokinase. And also, some long-term studies have shown the risk of non-melanoma skin cancer. So the last group of drugs will be the sphingosine 1 receptor inhibitors. So sphingosine 1, it can be considered as an attractant for leukocytes, which causes trafficking of leukocytes or lymphocytes from the lymph nodes into the areas that are inflamed. So in this case, in IBD, because of inflammation that's happening in different sections of the intestines, you'll have a high sphingosine 1, phosphate concentration. And the trafficking kinds of works in a gradient way, where areas which express a high level of sphingosine 1 receptors will have trafficking of lymphocytes to that area. And the trafficking of lymphocytes happens by one activation within the lymph nodes in terms of activation for the receptors for the sphingosine 1 receptor. So this group of drug utilizes this concept by, binding onto the sphingosine 1 receptors while the lymphocytes are still in the lymph nodes, and therefore, inhibiting the activation of these T lymphocytes by causing internalization and degradation of the sphingosine 1 receptors. In this case, therefore reducing the trafficking of lymphocytes from the lymph nodes into the tissue, in this case being the intestinal tissue. There are different types of receptors, being 1 up to 5. One of the drugs that's shown up there is etrasimod, which inhibits sphingosine 1 and 4 and 5. Other than etrasimod and ozanimod, which are what are utilized in IBD, there are also other sphingosine 1 receptors, one of them being fingolimod, which is utilized in multiple sclerosis. So fingolimod, amongst other receptors, also inhibits the receptors 2 and 3. And other than the role of S1P in inflammation, it also has a role in other organs, including in the heart, where activation of 2 and 3 can actually lead to bradycardia. So the issue of bradycardia was noted in fingolimod, and it was one of the worries in terms of patients who were put on the S1P receptors in IBD. But we shall see the incidences of the same when you're talking about these drugs. So one of the drugs is ozanimod, which was approved from the True North study, which showed a clinical response compared to placebo, both during induction as well as maintenance. And the next was also in terms of UC, elevate UC, etrasimod also showed after induction and after maintenance, it showed the clinical remission in compared to placebo. So as you note, we don't have, the trials utilizing, in terms of the use in Crohn's disease, did not pass, so they're not utilized in Crohn's disease. So what about the safety of S1P receptors? So one, there is peripheral lymphopenia just because of the mechanism of action inhibiting the aggression of lymphocytes from the lymph nodes into the systemic circulation. There is an increased risk of infections being nasopharyngitis, the same risk of herpes zoster as in the JAK inhibitors, and there could be a transient increase in the liver enzymes. But so far, we've not found any increased risk of malignancies. So compared to fingolimod, ozanimod, and etrasimod have not shown a significant risk of bradycardia, but still, prior to initiation of these medications, patients need to have, to have ruled out to have risk in terms of you need to exclude patients who have heart blocks, especially heart block type 2, or patients who have any valvular heart disease, or patients who've had a previous stroke. So these are patients who need to be excluded. So part of the screening is doing an ECG prior to initiation of S1P receptors. Macular edema is also one of the particular side effects of S1P receptors, especially in patients who are at high risk for macular edema. So patients who are diabetic or patients who have previously other comorbid infections that could increase their risk for macular edema. These are patients who need to have screening for the same prior to initiations and also subsequent screening while they are receiving S1P receptors. So having looked at all the different classes of drugs, we ask ourselves, how do we decide which drugs to administer for which particular group of patients? So there are these different tenets that we need to look at. So in terms of the patient, who of course is the key in terms of treatment. So look at the patient's age and see some of the medications which can be utilized in patients who are older versus the ones which can predispose for infections or other complications in patients who are younger. Pregnancy, as we've seen, we can't utilize the small molecules, and comorbidities is a key thing in terms of deciding on the drugs that we're going to use, and also preferences. For example, patients who would prefer to have subcutaneous administration as opposed to intravenous administration in cases where you have either form of medications. The disease is a key decision in terms of which medications we need to utilize. As you know, there are drugs which are approved in Crohn's disease, and there's some drugs which are approved in ulcerative colitis. And also within them, we also know drugs which are effective in the different types of disease behaviors. For example, the use of anti-TNFs in visualizing disease length and severity, also important in terms of consideration of the disease. And the extraintestinal manifestations is a key key decision in terms of when utilizing your medications. As we know, there are some drugs which have been utilized or approved for other extraintestinal manifestations, including psoriasis and arthropathies. Also, we need to consider prior treatment. As we've discussed, usually there is the law of diminishing returns, where with the subsequent treatment, they actually less and less efficacy. So you really need to get it first the right time. But also, as you are trying to position the other therapies, we need to look at the most efficacious in terms of your different kinds of trials, including the head-to-head trials. And then for the drug, the indication, the rapidity, the small molecules have been shown to be very rapid in terms of modifying your disease and also in terms of improving the symptoms. Some of the small molecules can improve the symptoms within 2 to 3 days of initiation of treatment. So that's something to consider in patients who require a rapid initiation of resolution of symptoms. And then another key thing is the combination therapy. We've already seen that you can combine anti-TNFs and immunomodulators, but as we shall see later, there are also different combinations in terms of advanced therapies and also sequencing. The safety is also another key use. So that's why all of the trials usually include a safety section in terms of using, finding which drug can predispose patients to infections, which drugs can predispose patients to malignancies, and which drugs have class-specific indications, for example, S1P in causing bradycardias. And also, you also need to consider the different drug-to-drug interactions. So finally, although we have all these drugs at our disposal, as we've seen, we rarely get, long-term remission in more than 30 to 40% of our patients. So this leads us to consider different kinds of other advances, whether clinical or scientific. So whether we have tools to be able to diagnose IBD before we actually get the clinical manifestations, probably because as much as we understand a lot of the pathogenesis of it, but there could be other modalities that we're still not able to understand. And if you're able to then have different molecular classifications of patients with IBD, then you can actually have new therapeutics as well as new combinations. And then probably we might improve in terms of the therapeutic ceiling. So some of the other advances that have been predisposed are, of course, early diagnosis and trying to find out whether there are any genetic studies or genetics that can actually identify patients who are at risk of developing IBD, and not only developing IBD, but also developing particular complications. In that case, we can risk stratified patients. So finally, in terms of combination therapy, as we've seen, there is really a big role for combination with immunomodulators, but there are different, forms of thoughts about whether you can actually combine different advanced therapies in terms of either combining a biologic and a small molecule, or combining two biologic agents, or combining, two small molecules. Of course, that will predispose. The obvious one of the obvious, considerations was the risk of, in terms of safety, the risk of complications in terms of combining that. But probably this should be a thought in patients who are, highly refractory IBD, or have high risk phenotypes. There are already case reports about different combinations for advanced combination therapy, but we won't discuss that is in terms of today's presentation. So thank you very much, and we'll have questions and comments from now. Thank you.
Thank you, Pascal. That was incredible. I don't know how much work you put into that because it's a massive, massive subject. So are there any questions from the audience? I see VG did make a comment. After 20 years plus of anti-TNF therapy, should we still be considering it as an advanced therapy? In my opinion, yes, we should, because it is still a biologic, whereas all the predecessors were non-targeted small molecules. So I think, yes, it still does fit into this category. Other questions or comments? Okay, so I've just jotted down a few things here. So the first is with regard to anti-TNFs, and Pascal did allude to this. The major drawback of this class of drugs is the lack of sustainability. So patients lose drug efficacy over time, which is not nearly as much of a problem with the other biological therapies. And then, of course, in our setting, the risk of TB is always a major concern. And just to mention that the anti-TNF lymphoma risk, there is a slight risk with anti-TNFs, but most of the risk is actually driven by a combination with thiopurines. Looking at the anti-integrins, natalizumab, of course, carried a significant risk of progressive multifocal leukoencephalopathy because this drug prevented lymphocytes from entering the central nervous system and thereby reduced trafficking, allowing things like the JC virus to proliferate. But of course, with vedolizumab, given that it's got a gut-specific mechanism of action, we wouldn't really expect this. And to date, in my knowledge, there's only one case of PML that's been reported, not in the data that you mentioned, but it was in an HIV positive patient, which is, of course, an independent risk factor for PML. Then in terms of the specific IL-23 antibiotics, just to point out that guselkumab, we now have two studies, one in ulcerative colitis and one in Crohn's, looking at subcutaneous induction, which was very successful. So guselkumab is now approved for both intravenous and subcutaneous induction, which is obviously very useful for patients. It's also the only one of the IL-23s where there's the same dosing regimen used in both Crohn's disease and ulcerative colitis, whereas mirikizumab, risankizumab, the dosing is much more complicated in terms of different doses, different time points that are used. And just one other thing about guselkumab is that it has a second mechanism of action from the other IL-23 specific monoclonal antibodies, and that it also binds CD64. Whether this is going to really equate to much better efficacy over time, I think we still wait to see. Just in terms of the JAKs, so a lot of the cytokines that we block with our biologics actually signal through the JAKs, particularly IL-12 and IL-23. But interestingly, TNF alpha does not signal through JAKs, which is just an observation. Okay, one of the side effects that wasn't mentioned unless I missed it, and it's a major one for young patients, is acne with the JAKs. It's a class effect, and up to even 20% of patients can suffer from acne, something that you need to disclose upfront. It can be treated as one would with topical therapies, antibiotics, etc. But just to point out, even though it's never been proven, there was always this concern that Roaccutane could actually trigger or be a cause of IBD. It's never been shown, but one just has to put that in the back of the mind for the patients. Right. You mentioned from the rheumatoid arthritis literature this risk of major adverse cardiovascular events, venous thromboembolic events, malignancy, which came from the oral surveillance study done in patients with rheumatoid arthritis. Very, very different type of patient from our patients with ulcerative colitis who receive tofacitinib. And we now have data from the Octave program of tofacitinib in UC right up to 7 years. And I think it's 8 years now, which really don't show any signal for major adverse cardiovascular events, venous thromboembolism, malignancy. Again, our patients are a very different phenotype of patients. They're younger, they're less likely to have other comorbidities. In terms of the S1P receptor modulators, so etrasimod, there are no head-to-head studies, but etrasimod does seem to have a slightly better safety profile than ozanimod. And this is because it has a much shorter half-life. So basically, you're going to get much more rapid restoration of the peripheral lymphocyte count, which is obviously quite reassuring. With ozanimod, those lymphocytes can stay down for up to 3 months. Okay. And the second benefit of etrasimod over ozanimod is that you don't have to slowly titrate the dose up over a 1 week period. You can go straight in with the full dose up front. And then finally, just about combination therapies. So yes, this is obviously going to be where the future lies. And there are a number of studies that are actually being conducted at the moment. I think there might be some in South Africa that are being done. The DUET Crohn's disease and ulcerative colitis study, which is looking at combination of guselkumab and golimumab versus both alone. And then we also have, there are some other the studies in progress at the moment to looking at combination therapies. But I think we need to have probably more information before we can start routinely using this in clinical practice, because let's face it, it's going to be extremely expensive. Having patients, for example, on a JAK and vedolizumab, you really are going to be pushing the finances to the max. Okay, does anybody have any questions for myself or Pascal? Okay, VG, when starting an advanced therapy in a patient, I can't actually see it because how long do you overlap? Sorry, I'm missing this question. Let me just go back. VG, can you just say it?
Hi, Jill.
Hi, thanks.
Yeah,
Sorry, I'm just struggling to see it.
yeah, yeah. So actually, obviously, we have that situation where somebody's on AZA for a long time, usually in our situation, over maybe a year of adequate amounts of AZA, and finally you get access to one of the advanced treatments like infliximab or adalimumab. How long do you lap treatment? How long do you keep the patient on the AZA, which obviously the patient hasn't been responding to anyway? Or should you just stop and say, I'm assuming, of course, that this patient is going to respond to an anti, like in TNF, for example.
Sure. So with biologics, one has absolutely no concerns at all. Of course, we use infliximab in combination with azathioprine very often. And although not as much in adalimumab, if patients develop a low dose antibodies, we may also give an immunomodulator. So with biologics, no problem at all. You can start straight away. But with other immunosuppressive drugs, you may want to give a little bit of a gap. Although exactly how long, I'm not sure, but I don't think it's something to be too concerned about. Other questions? I did see something coming up.
I think Dr. Siabi has a hand up.
No, could you also just say in person? Sorry, I'm really struggling to see the messages.
Okay, hello, thank you.
Hi there.
So I just wanted to share some experiences because, as you know, we have very limited access to anti-TNFs. So just in terms of the patients that we've been treating, unfortunately, we've had a few cases of TB. One such recent case was a young man who'd been on the etrasimod trial last year, and he didn't do well at all and ended up requiring right hemicolectomy. So we put him on infliximab post-operatively, and he's now subsequently developed disseminated TB. So that hasn't been good. Yeah, and some of our patients on Remsima have developed, the psoriaform rash, and one had such a bad rash that we actually had to discontinue. So now it's just a matter of figure out for it. I think, yeah, we just need to figure out what to give her. And yeah, so I found that like these young people with a limited right-sided disease, we had one such young person who had this inflammatory mass, and the surgeons weren't really keen to go in. So we drained the abscesses percutaneously, and then eventually, once the collections were cleared, we started him on TB treatment. But he said just progression of disease, and I'm sending him to the surgeons for a limited right hemi. So the response with the limited access to anti-TNFs, maybe I'd say like 50% of patients have been okay, but 50% have had like complications, mostly skin and TB, and just progression of disease despite no antibodies, no drug levels. Actually, two are going for surgery soon. Yeah.
Yeah, I agree with you. We've had a lot of cases of TB. It's always very, very, very concerning. To the extent now we don't actually look for latent TB. Everybody in our unit that gets an anti-TNF just goes directly onto TB prophylaxis. But despite that, we've seen really quite a lot, and it's problematic. We
Mm.
have used vedolizumab in these patients, but unfortunately, vedolizumab being used after an anti-TNF, its efficacy is not very good, especially in Crohn's disease. So we've tried to use that. Ustekinumab would be my first choice in somebody who's had TB, and they've got all the IL-23s, and as well as ustekinumab have an excellent safety profile, and really no signal for TB has emerged in any of the large randomized controlled trials or real world evidence. So I feel very comfortable using those classes of drugs. The JAKs worry me a bit more. There's most definitely a TB risk there. So yeah, but ustekinumab's wickedly expensive, although the generic, no, sorry, apologies, the biosimilar
Biosimilar.
is, is going to be available very soon. I think
Mm.
they're planning to launch it in the next couple of months. So hopefully
Yeah.
we might be able to get our hands on that.
Oh yeah, and there's also the worsening of arthralgia or arthritis with vedolizumab,
Oh,
which we're
absolutely, absolutely.
experiencing now with our one of the two patients that we were given permission to use Vedo on. One has arthritis, so I just told her to bash on
Yeah,
salazapine, methotrexate, because
yeah.
after this, there's nothing else.
There's nothing we can offer unless she can go
Mm.
on to a drug trial, which fortunately we have got quite a few colleagues in South Africa that are doing some of the fantastic new drug trials. But of
Mm.
course, not all patients are eligible,
Yeah,
especially if they've had TB, then they're definitely not
TB.
going to be
Yeah.
eligible.
Mm.
Any questions, comments? Pascal, would you like to make any comments further after your extensive reading?
I mean, so just the issue about, I mean, it's an unfortunate issue about, I mean, having all the knowledge and, I mean, knowing what's supposed to be done, but in terms of limitation, in terms of what we can give, especially in the state. So that's always a limiting factor. I
Yeah,
mean, bigger here as opposed to, I mean, other sub-Saharan African countries where even the diagnosis of IBD is difficult. So that's just
absolutely.
the
Absolutely.
concerning thing.
We might. Hopefully I know a little thing or two about inflammatory bowel disease, but I haven't used most of these drugs. So, it's all great to know the literature, et cetera, et cetera. But without that personal experience, at least anti-TNFs and Vida and ustekinumab do have some feeling for. But for example, upadacitinib, it's approved in South Africa. It's a fantastic drug, absolutely fantastic. We've also got tofa approved, and we have had a few patients on that, but we're never going to get access to upadacitinib for the foreseeable future because of the costs involved. So it is a problem for all of us that train or work in the state sector, and all of the fellows that we train. So yeah, not much we can do about that, unfortunately.
Mm.
Okay. Any other questions, comments? I don't know if there's any other consultants on that may want to share their 2 cents worth. No. Okay, well, thanks everybody for joining. So the next session will be with Prof Shedi. That's in 2 weeks' time, and it's going to be a feedback session. So I think she would really appreciate all you guys joining to see how the program can be improved, what aspects maybe haven't been covered, what could have been covered in more detail. I think that's the feedback that you really need to give to her so that she can carry on working on perfecting this. Anyway, have a lovely evening, everybody, and yeah, well, I will see you next year. So have a good Christmas and New Year, etc.